Good evening. I am Dr. Pete Thomas, Chief Medical Officer of MD Newsline. MD Newsline is a health disparity focused educational platform for healthcare providers and healthcare influencers with a mission to increasing the access to culturally relevant and accurate research and resources. Our experts and advisors and editorial contributors are dedicated to helping to curb healthcare disparities while helping healthcare providers take a more culturally sensitive approach to patient care and disease management. Please be sure to follow us on Twitter, Instagram at MD Newsline, and visit us on mdnewsline.com today. Today, we're going to be talking about vitiligo. This is a condition that results in patches of skin that loses its pigment. While with time, this discoloration spots typically get larger. Any portion of the body might be impacted and by this condition. Additionally, the mouth, inside, and hair are also susceptible. Today's webcast discussion will be focused on exploring vitiligo treatment options. I'm excited to have today the one and only Dr. Brittany Oliver, a board-certified dermatologist, here to answer some questions and treatment options for vitiligo. Dr. Oliver, welcome. Please introduce yourself.
Thank you so much for having me, Dr. Thomas, and for that wonderful introduction. Like you said, my name is Dr. Brittany Oliver. I am based in Kansas City, a suburb just outside of Kansas City, Missouri, and I'm a board-certified dermatologist. Just finished up my first year out in practice, have been moving all around. I'm very excited to join today.
That's awesome, Brittany. So, if you could just do this for us, because a large part of our listening audience, our patients, can you just break down what is vitiligo? What is it?
Sure. So at the simplest kind of explanation, it is an acquired disorder of pigmentation. We really don't have a complete understanding of what causes it at this time, but we believe that it's likely both a combination of genetic and non-genetic factors at play. As you mentioned, those with vitiligo experience the development of white patches of skin related to the selective loss of working functional melanocytes. Melanocytes are the pigment-producing cells in the skin. This most often involves the face, peripheral body regions like the fingers and the toes. And although it can occur at any age, about half of patients develop vitiligo before age 20. I think it's important to know that there are some associated autoimmune conditions, such as thyroid problems, alopecia areata or autoimmune hair loss, rheumatoid arthritis, diabetes. So those are things that, particularly if you're diagnosed with vitiligo at a later age, should be screened for. So that's kind of basically what vitiligo is and what you can see associated with it.
So I'm a patient and I take a shower. I've been looking at my body for, 30, 40, 50 years. I noticed a patch of skin that is not normal or it's losing its pigment. What would you recommend that person to do?
I would recommend seeing your doctor. Oftentimes, this is something that's first brought up in a primary office visit with your primary care physician. If it's just one spot, that primary care provider can refer you to a dermatologist who is well-versed in treating vitiligo at the earliest stages, if possible. There are specific ways that we diagnose vitiligo using tools if there's any uncertainty, but from what we know about the disorder, the earlier you intervene, the better. And so I think it's best to bring that to your trusted medical provider's attention as soon as possible, whether it's your primary care provider, if that's the easiest, or if you can directly see a dermatologist, that's probably the best avenue to get an accurate diagnosis and comprehensive treatment plan.
Okay. And can you tell us about the differences between vitiligo and people with different skin tones, and how do you identify vitiligo in those patients?
Yeah, firstly, I think it's important to know that vitiligo prevalence appears to be about equal between men and women, and there are also no differences in rates of occurrence by skin type or race. However, vitiligo can be especially psychologically devastating in darker skinned individuals simply because the contrast between affected and unaffected skin is greater. It makes it much more noticeable. As far as how I identify vitiligo, as mentioned, we have certain tools that we use. The diagnosis is often made clinically, meaning testing and lab work and biopsies are not usually necessary. All I have to do is look at the skin in most cases to know that I'm dealing with a diagnosis of vitiligo. We often will use the aid of a tool called a Woods lamp. It's basically a handheld UV light, black light essentially, which highlights areas of skin that are completely lacking melanin. If there is any doubt, a biopsy can be performed and would really just show a complete absence of melanin in the skin. But really, the Woods lamp is usually all that we need if there's any doubt. It really shows crisp edges of the affected skin. It's a stark kind of white blue color that really removes any doubt from the diagnosis. But again, usually I look at it, I can tell.
So, not so just for patients who might be watching, biopsies are not necessary.
In most cases, biopsies are not necessary. So we'll probably get into this later, but there are a variety of clinical manifestations and presentations of vitiligo. There are cases in something called trichrome vitiligo where there are phases of skin where it's kind of between the normal color and complete depigmentation. And I could imagine a scenario where someone might have a predominance of those lesions. It looks hypopigmented, not depigmented. The difference there being fewer melanocytes or fewer pigment producing cells versus a complete absence of working pigment producing cells. In that case, a biopsy could be helpful because there are a lot of disorders that can result in hypopigmentation, ranging from types of cutaneous lymphoma to chemical reactions, infectious diseases. So usually it's not necessary, but there are some scenarios where if the diagnosis is in question, it would be helpful.
All right, so this is good because this sort of ties into our other discussion or something that you mentioned earlier. So vitiligo can be a diagnosis that's on its own, but it also can be a presentation of other disorders, other skin disorders, or not, or non. So let's say autoimmune disorders.
Mm-hmm, mm-hmm.
So you can lose your skin tone, the patchy loss of skin pigment from autoimmune disorders like diabetes and lupus and things like that too, right?
Mm-hmm. Yeah, there are a lot of diseases that have both internal and external manifestations. Lupus is kind of its own thing with some classic cutaneous findings like that butterfly rash, for example, would be the classic with lupus, for example. But yeah, there are certain infectious diseases that can have light spots. Syphilis is an example of one of them. Yaws, Pinta, other spirochete kind of driven infectious diseases can also have light spots, and then certain forms of cutaneous lymphoma. So yeah, I mean, there is a differential diagnosis for that presentation, but it's also the history, the story. Where has that person traveled? Would they even have been a place where one of these infections is endemic, or is something about the pace of the development of those lesions fitting more for vitiligo versus something else? But usually it's just that stark white colored skin instead of just the lighter brown or tan that makes it really just be one of a couple of things.
Okay. How do you decide on the treatment options? Like what goes through the head of a skilled dermatologist like yourself? How do you decide?
So I use a pretty individualized approach based on a few factors that I really just discuss openly with my patients, knowing that the course of disease in a lot of people is really unpredictable, and therefore the response to treatment is going to vary as well. But I also think it's just important to point out that this psychological distress that can come about as a result of this loss of pigmentation can really impact quality of life and increase the risk of psychiatric illness, such as depression. And I really don't view it as a cosmetic disease or disorder. So treatment, first of all, can and should be offered to those affected. Therapies are not one size fits all. I navigate, where to start by first listening to my patients, allowing them to share their story with me, and following this with an open discussion that I hope empowers them with knowledge about their own condition. Education is so important because certain misconceptions and stigma surrounding vitiligo do exist, particularly in certain cultures. Like I mentioned, there are some infectious diseases that manifest with light patches of skin. And there are cultures and communities where these people are excluded from participating in activities. Women with vitiligo have a harder time finding mates and husbands because it's thought to be a sign of transmissible disease, which is just not. And I've also had patients come to me dealing with this condition for years and tell me they never sought out help from a doctor because they believed there was nothing that could be done, which is heartbreaking because, as we will discuss, there is a lot that we can do. So with that background, I really start with, that goals of treatment, which really I try to make clear from the start. We want to halt progression of the disease and induce repigmentation as much as possible. Optimal treatment really depends on the subtype of disease. There's two main subtypes, localized and generalized. Essentially, that just describes how widespread the disease is, with localized variants restricted to small areas, such as the mucous membranes only, like the lips, or patches involving a single unilateral segment, which is called segmental vitiligo. And then there's generalized variants, self-explanatory, much more widespread distribution. Treatment also depends on which body parts are affected. Some are in more sensitive locations than others, and also the overall body surface area involved. Someone with 2 to 3% involvement is going to need something different than someone with 40, 50% involvement. And throughout the process, since response to treatment is slow, they should also be offered counseling on concealment techniques as treatment is ongoing. While makeup is temporary, the effect is immediate and may just give someone the confidence to walk out the door and continue living their lives to the fullest while they're actively seeking treatment. So that's kind of my process.
So, Dr. Brittany, I'm a primary care internist, and I will interact with patients often, and they will say, "I went to this doctor, and they didn't do this for me, and they didn't do that for me." So, as a Black board-certified dermatologist, what is your approach to reassuring patients of color that they are not being blown off, they are not being dismissed, their insurance is as good as anyone else's? Because I feel it's my responsibility. I feel like this was God's way of putting me in a place where I can help my patients. What is your approach? And I can tell you're probably passionate about this. What is your approach to helping to reduce the feeling that our patients have that they're being not treated appropriately?
Everything you said really, it does resonate with me. I'm practicing in an area where, well, first of all, there are not that many Black dermatologists, period.
What percent? Give me the percent.
I mean, it was like 3%. That was like the most recent statistic.
Wow.
That is starting to change. That is starting to change in the last, I would say, maybe 3 to 5 years. A lot more attention has gone into recruitment of Black and also Latinx communities to the field of dermatology. Extra effort's been put in recently, but as far as the number of board-certified practicing dermatologists is low to begin with, and then where I am at in Kansas City, it's an even smaller pool. So I came here feeling that I had the potential to be a resource for a large population that didn't otherwise have anyone that looked like them to go to for their skin concerns. So I think, a lot of times I'll have someone come into my clinic and they're just excited to see me. They're just happy and feel at peace to be in my clinic. And there's just kind of that understanding, without having to say any words of, why we're both mutually happy to be right here where we are right now. I
Mhm.
think my approach is just to listen.
Okay.
That's a big one.
Yeah.
Um, I've felt that, feeling of being brushed off. And honestly, one of the worst pieces of feedback a patient could give me is that I didn't spend enough time with them, because a lot of dermatologists see 40, 50, even more than that patients a day. And I don't see that many, and that's intentional. I want to give everyone the time that they deserve, regardless of skin color, regardless of insurance status, and all of that. But knowing that I might be a particularly special provider for someone who, is in a place where they don't have any other Black dermatologists. So listening is key, number one. Active involvement in decision making is another big one. Um,
Yes.
and also taking into account certain, I see a lot of hair disorders, for example, off topic, but that's another thing that someone on the outside might not understand.
Yeah.
We might use terms about different hairstyles that someone else may have never heard of.
Yeah.
And even just that little bit of understanding can go so long in establishing rapport.
Yeah.
And it's really no different with vitiligo.
Yeah.
I mean, it's true. The fact is, vitiligo is more visible in darker skin, and therefore is more distressing. You could have someone with light skin who you can barely see the patches and it doesn't bother them, and they don't want to treat it necessarily. So it's just going to be a very different conversation. So those are my approaches.
Yeah. Have you noticed certain treatments work better? I think you probably touched on this, but just if you could clarify it for me, that is it that certain treatments you found in your experience, this tends to work better than these treatments?
Yeah, so it is a tough question because it really does depend on the situation and type of vitiligo. Some forms, like the segmental form that I mentioned earlier, can be particularly treatment resistant. And then certain locations, face, neck, trunk, respond better to therapy as compared to, say, hands, feet, lips. In general, though, I'm a proponent of a combination approach. That is to say, I like to utilize multiple modalities at the same time. I use topical creams, phototherapy, and or lasers, and if rapidly progressing, I might even use oral therapies, steroids, all at the same time.
Oh, wow.
So currently, first line treatments are going to be topicals, topical steroids, topical calcineurin inhibitors such as tacrolimus, topical JAK inhibitors. Are a newly first line option, specifically ruxolitinib, which is sold under the brand name Opzelura, which is very exciting because earlier this year became the first FDA approved drug for vitiligo repigmentation that we have. So everything else we use is off label.
Right.
But yeah, I'm basically using one or more of those topicals in combination with phototherapy, another first line option, especially if they have more than, say, 5 to 10% body surface area affected. So in the right patient, I think combination therapy works great. Some experiencing an accelerated course, that would be that reason to use steroids. Excimer laser is also very narrow wavelength treatment that can be used for localized disease, and that can work really well. So late stage, that would be kind of another special situations. Say someone's had long-standing vitiligo for years, never did anything about it, and yet it's not progressing. That's going to be harder to treat with these first-line creams and phototherapy. So that you might reach for surgical modalities, grafting of melanocyte transplant, for example. So I guess the last special situation that would work very well, depending on your goals, would be complete total body depigmentation. So I think it's important for people to realize that that's an option. For a lot of people, it's going to be a last resort, and for really recalcitrant, widespread, we're talking more than 50% body surface area vitiligo, where it's almost easier to remove the remaining pigmented patches because there's so few, then try to repigment the whole rest of your body. So there's a treatment called monobenzone that could be an option. So it's permanent, not reversible. So obviously needs to be undertaken with care and careful thought about, how this is going to affect your sense of identity, and such. But it can be effective at getting rid of the remaining patches. So I think our treatments work pretty well. Like I said, the earlier you intervene, the better. The younger you are at onset, the better the prognosis as well.
So you mentioned so much. I was just trying to juggle everything. But so in terms of the more common, like if you go see a dermatologist, most dermatologists will offer what first, and then when do we say, or when can we say, hey, I've been to a dermatologist, this hasn't worked. I want the new sexy thing that's out. So what's the more common treatment
Mhm.
modalities, and then what's
Mhm.
the thing that not a lot of people will know about?
Okay. Yeah, I think probably most common thing that a patient would be offered would be a topical cream, topical ointment, falling in one of now three classes of medication. So one would be topical steroids. We usually need high potency, very strong ones, which have to be used carefully due to side effects, local side effects, but still side effects nonetheless. Um, After that, or even first, might be someone's personal preference to do a topical calcineurin inhibitor like tacrolimus. So these are things that work on the immune system locally to suppress inflammation. So basically, these are anti-inflammatory treatments.
Okay.
The JAK inhibitors like Opzelura, ruxolitinib, that probably is the new sexy treatment,
Okay.
but it's more of a targeted immunotherapy. It's newer, but was very exciting to have another option for patients, and especially to have one that's on label.
Okay.
So that's very exciting. So I would say just in the last 5 months, maybe people are starting to prescribe topical ruxolitinib or Opzelura more frequently, even as a first line option. But
Wow.
historically, it's been topical steroids, topical calcineurin inhibitors.
If you were so, is that something you would recommend a primary care doc doing, or you would prefer them to send them to you?
I mean, I guess it depends a little bit on how quickly you could get a patient into dermatology if needed, because, there's a shortage and sometimes wait times are months long. So to me, it makes sense, if you're capturing a patient with vitiligo and in your area it's going to take 3 months to get someone into dermatology, you can initiate that referral at the first meeting while you start a topical therapy.
Hmm.
And if they're not improved at follow up and you don't know what to do next, then they already have a connection, they have an appointment waiting, something like that. So I think it's perfectly fine for primary care doctors to utilize things like tacrolimus, topical steroids. I mean, the potency you use is probably going to vary based on body site, trunk, extremities. You can use something very strong like clobetasol, mid potency. I mean, sometimes you need strong for segmental vitiligo on the face. You need to hit it hard, but we traditionally try to avoid using super potent topical steroids on the face. But
I,
sometimes you have to.
I think it should be noted that what a dermatologist thinks is super potent and what we think is super potent is there's a difference. So just to
Probably.
clarify to our audience, you might be frustrated with your primary care doctor because there's only so much. We take an oath called the Hippocratic Oath, and it says, "Above all, do no harm." So we're not trying to cure your vitiligo and then give you some sort of severe skin infection or something like that. So, and this is probably a little less applicable to, but what would you consider to be super potent versus what you think a primary care doctor could write for?
Yeah, I mean, sure. Our comfort zone for topical steroids is, I mean, that is our bread and butter.
Yeah.
So I am very comfortable counseling on appropriate use because I do it every day.
Okay.
So for me, super potent, probably the strongest we have would be things like betamethasone, clobetasol.
Mhm.
We usually reserve that for trunk extremities. that sort of thing. Mid potency, which is also nice because it comes in a larger quantity that you can order for your patient, would be something like triamcinolone.
Hmm.
Um, Again, in most cases, we're not using that on the face. We're using that below the neck. But in certain situations, it's necessary to do that. So, and then low potency would be something like desinide, hydrocortisone 2.5, something like that. So I have a few in each class that I select from. Everyone has their favorites.
Okay. Well, that was good. Thank you for, helping me with that,
Sure.
because this is something that I experience, and patients will say to me, well, this is not working. What's it? I'm like, we got to go see derm because I'm not going any further than this. And I've been doing this a long time. What, in terms of phototherapy, how long would you tell patients it's going to take to see an improvement? And is that an individual thing, or what would you say? What would you say?
Yeah, I mean the improvement you see with phototherapy, it's slow, it's steady. It's not going to be an overnight change, that's for sure.
Okay.
We have different studies reporting different things. We try to quantify the improvement. So there was one study that showed an average of about a 25% improvement after 3 months. In their cohort of patients, about 50% improvement in 6 months, and then about 75% improvement after 9 months, which this is narrowband UVB phototherapy. So when I say phototherapy for our purposes, I'm talking about narrowband UVB. There are other types, but this one has surpassed the other types to become our preferred modality, just due to favorable side effect profile and increased tolerability. So narrowband UVB is what we'll use the most. If you're not responding after 6 months, that's probably a sign that you need to switch. So 6 months, no response, you're probably not going to get a response. But usually around 3 months, people are starting to notice an improvement.
And so, how often are you coming in? What's the frequency like?
The recommended regimen is typically 2 to 3 times a week. So it is a commitment. It's not always feasible for people to be able to make that commitment 3 times a week going to an office, even though the duration of treatments is short. Just getting there, taking the time out of your day 3 times a week can be a hurdle. So yes, 2 or 3 times a week with a higher likelihood of earlier repigmentation if you do go 3 times a week as compared to the 2. There's actually surprisingly little evidence to guide us on duration of treatment, optimal frequency dosing for vitiligo. It's unfortunate, but we kind of just have to go based on current thinking, which is as long as the patient is improving and the side effects are minimal or tolerable, the treatment can be continued until you plateau, until you're not really seeing any further improvement. Now, there is a risk of relapse after stopping treatment, whether it's phototherapy or topicals, which is why maintenance therapy has been proposed once repigmentation has been achieved. That risk of relapse is higher in the first year after treatment usually. So maintenance treatment might look like applying topicals to all the formerly affected areas. It might mean a reduced maintenance schedule of phototherapy, twice a month, once a week, something that's modifiable, that is really decided on by the patient and the provider, the clinician, because there's no set algorithm for this. We have treatment algorithms, like if this, do this, if this percent BSA, go down this path, but specific to phototherapy, there's not one agreed upon regimen. But that's kind of what you can expect.
Wow, that's just so interesting that we wouldn't have done some evidence-based research on that, to have some, just to be able to inform our patients. Look, this percent of people will improve if you do this versus that. What would you say? How long will the patient spend for their phototherapy session? Like, what would you estimate the treatment time might be?
Per session?
Yeah, per session.
So phototherapy, it's interesting. So the way that it works is the goal is to start at the lowest possible dose of UV radiation and slowly, incrementally increase the exposure it's usually by exposure time. So you might start a couple minutes in there up to a certain number of minutes per session, and that's increasing the dose. So the treatment is a few minutes at a time. This is not like you're spending 30 minutes, an hour in the light box.
Oh,
It's short.
oh.
Hmm. Yeah,
That's
the end point is kind of when if you have, there's like a minimal erythema dosage that we kind of use as a titration, and that's going to change depending on your skin tone. So if you have just a light pinkness on the skin, that's kind of your endpoint, and you with successive treatments with incremental increases in the dosage, you can tolerate more and more.
and in terms of side effects, how would you counsel patients in terms of side effects?
So as far as side effects go, narrowband UVB, it's generally pretty well tolerated. You might experience itching, burning, redness is almost, it's very common to have redness after treatment. It's almost expected. And like I said, that's kind of our goal. The goal is
Okay.
not to burn. Burning is an unwanted side effect, but a
Okay.
little bit of pinkness to the skin is very common and usually resolves within about 24 hours. But transient hyperpigmentation, if someone is operating the light box that doesn't know what they're doing, for example, has not been properly trained, that's when you're, getting into really rare adverse effects such as blistering, skin ulcerations.
Sure.
But the more common things would be redness, itching, dryness. So you're going to want to use a lot of moisturizers after the treatment. So that sort of thing.
And so we talked about the combination treatments. So it's okay to be on let's say, a topical steroid and get phototherapy.
Good question. Yes, it is. Now, with the topical ruxolitinib, there's a little bit of debate on that. And it's currently not being advised to use that in combination with phototherapy.
Okay.
Um, but I think experts in the field, would say that is something that we're still learning more about.
Yeah.
But to be on the safe side right now, it's not recommended.
Okay. Okay. Well, that's good to know, because I'm sure some patients are, because of you're right, some of our darker skinned patients, the frustration and the depression and the isolation even would just, I can imagine they just want it to go away, right? And
Yeah.
so I'm like, give me the strongest thing you got, and put that on there too. And so, but we should make sure that above all we're not going to do any harm. And so
Exactly.
yeah. And now, is there a such thing as, should we be selective in which dermatologist we decide that? Is there a specialty dermatology that's more familiar with vitiligo that we should go with? What would be your suggestion?
I would say all of us, any board certified dermatologist will have been trained to recognize vitiligo, manage vitiligo. We, depending on your practice population, any general dermatologist should feel comfortable managing this. There are certainly going to be people who've developed a specific interest in this, and usually you'll find them at academic institutions, but not always.
Mhm.
So certainly I think the average person would do well seeing any general dermatologist who is doing medical dermatology. If you are looking for an expert who's dedicated their whole career towards vitiligo, there are people out there who do nothing but vitiligo and research it and participate in clinical trials and things of that nature. So I think, in my opinion, any general dermatologist can handle vitiligo.
Okay. Okay. And is there what types of patients should avoid phototherapy, would you say? Any particular type of patient should avoid it?
Yeah, I would say, in my opinion, there are certain populations, for example, people who have a disease that is exacerbated by UV light. Lupus comes to mind, dermatomyositis, so certain photosensitive skin conditions.
Okay.
Um, people who are taking medications that make them more sensitive to the sun, tetracycline antibiotics, that's a very common one, doxycycline, very photosensitizing.
Oh, wow.
So that's a conversation that you have with your doctor. They need to know all of the medications that you're on. They need to know your complete medical history to decide if this is right for you. There was a thought, and there is still concern, I suppose, about the risk of phototherapy with development of skin cancers later. So this was a bigger problem when we were using UVA light,
Okay.
PUVA, Sorolin, and UVA light. With narrowband UVB, there has not been found an association between the development of either melanoma or non-melanoma skin cancers after treatment, but the risk is a little bit higher if you've had UVA treatment in the past. So if you've had UVA treatment in the past, have had a skin cancer in the past, and are being considered for narrowband UVB phototherapy, that is definitely something to let your doctor know. And I mean, everything is going to be a risk-benefit association. Certain things are an absolute contraindication. Other things are relative or, a little bit less of a risk. But certainly if you're on medications that make you more sensitive to UV radiation, photosensitizing or photoexacerbated skin conditions or autoimmune diseases would make you less of an ideal candidate.
Yeah, Dr. Brittany, and also you mentioned that, after you, let's say, discontinue phototherapy or even some of the topical creams, there's a possibility that it might reoccur. Am I correct in that?
Mm-hmm.
Yeah.
Yeah.
Okay. So yeah, I know this is frustrating. Can you talk to us about insurance? I know a large percent of our patients have a variety of different insurances. So can you talk to us about the various insurances and what insurance tends to have more problems with covering some of the more successful treatment options, and which ones tend to, they hardly pay for anything?
Mm-hmm. Yeah, so there's a wide range of medical policies among health insurance companies in their coverage of vitiligo treatments. While some companies do cover FDA-approved treatments, which again, there aren't that many for vitiligo. There's now two, one for repigmentation and one to just take all your pigment away. Others don't cover anything at all. Others cover a portion and have limitations on coverage. Sometimes considering a home phototherapy device is in the long term, more economic, depending on the individual. They can cost hundreds to thousands of dollars, but some insurance companies will cover at least a portion. The short answer is it depends on the individual plan.
Okay.
A lot of times, if the initial claim is rejected, it's kind of a regroup moment with the dermatologist and the patient. If there's anything I can do to advocate, write a letter, cite some literature studies. A lot of what we have is off-label, and so we don't really have too many first-line options by their criteria. So sometimes writing a letter helps.
Yeah.
But it's very variable.
So do you advocate for prior authorization completions, things like that? And does that help?
It sometimes helps, but not always. So I'm lucky in that I have a team that helps with prior authorizations and alleviating that burden.
Yeah.
But sometimes it is still denied, and there are levels of appeals that you can go through. Sometimes ending in a peer-to-peer communication, but it's usually, I'm appealing to someone such as yourself who's in primary care, and we're kind of having a discussion. It's not necessarily a dermatologist I'm talking to. It's often, family medicine, internal medicine, or some completely other specialty where we kind of, I lay it all out, my reasoning, citing the literature, trying to express the limitations that we have, and just doing the best for my patient.
You should just say, I'm Dr. Brittany, and what I recommend, period.
I wish that worked. I would say my life would be so much easier if that just worked for
Our,
everything.
our patients don't know the extent to which we have to fight for them and
Right.
what they
There is
need.
a lot that goes on behind the scenes.
Yeah, yeah.
Mhm.
Um, so with that, is there anything you want to leave us with in terms of the sort of frequency of vitiligo and what should we uh, advocate for ourselves in terms of when we go see our provider regarding vitiligo?
So, yeah, as far as kind of overall prevalence, it's not all that uncommon. I think some estimates are about 1 to 2% of the U.S. population. But I think the highlights, the key takeaways are if you're noticing something, it's better to bring it up to your trusted medical provider, doctor, as soon as possible, especially if it's rapidly progressing, like you're waking up every day and the spot is bigger, you've got a new spot. Don't delay, because if you do, you're, impacting the chances of success with our current treatments. We have great treatments, but if the vitiligo is allowed to become stagnant and stable to where it's inactive, the treatments are going to be a little bit less helpful, and it's going to be slower to respond. There are different patterns of vitiligo. They respond differently. I think that's important to understand so that you can counsel patients appropriately. Like lips are going to be a lot tougher to treat than face, neck. Hands, fingers, a lot harder to treat than your trunk and extremities, like your upper arms. So I think setting expectations and coming up with a plan early on is really going to help the patient have as good an understanding as possible about their own disease and how to live with it, and what they can do and what medical science has given us the ability to do for them.
And I know you went over this earlier, but messages to the primary care docs out. What
Mm-hmm.
what and when, like I know you said we could start some of the topical things, particularly if there's a shortage in dermatology, which we know there is, and there's
Mm-hmm.
always a long wait to see derm. But
Mm-hmm.
what would you recommend for primary care docs who are seeing these patients, their first sort of line of defense?
Mm-hmm. So I think having a basic understanding of vitiligo, and also its associated conditions. So especially if it's popping up for the first time in mid or late adulthood, know to screen for thyroid problems, know to screen for diabetes, alopecia areata, other autoimmune conditions. The thyroid is a big one. So just taking a really good review of systems, asking about family history. So gathering all that data so that we know how to capture other things going on internally. Because that, you discover hypothyroidism in someone who's presented with new onset vitiligo. That's your court completely, managing hypothyroidism or hyperthyroidism. So that is something that you can completely manage and make a huge difference for the patient. So recognizing associated comorbidities, initiating topical anti-inflammatories early, I think is going to be huge for patients if you're able to do that.
No, I know you mentioned syphilis earlier.
Mm-hmm.
However, syphilis tends to give you the rash on the palms and the soles of your feet, right? So,
Mm-hmm.
is that the presentation that we're talking about, or is there another presentation that can resemble vitiligo?
Usually, if it's going to happen in syphilis, it's usually hypopigmentation,
Okay.
not complete depigmentation.
Okay.
So I mentioned as something as being on the differential. It's not that similar to us,
Okay.
but certainly there is a variant where, in addition to getting the hyperpigmented spots on the hands, another manifestation could be light spots on the skin, but
Okay.
it's usually not complete depigmentation.
Okay. Okay. Wow, this is great. Dr. Brittany, thank you so much. This was so informative.
I had a great discussion. Thank you so much for having me. Hope it
This
was helpful and informative.
I think one is it's very inspiring to, and I think our listening audience should know that dermatology is very competitive, and so to see one of our own be in your position, we are so proud of you, and I do want to thank you for taking your time out this evening to educate our audience regarding vitiligo.
Thank you so much. I hope it's not our last time doing one of these discussions. This was fantastic.
Yeah, absolutely. So I want to thank our attendees. I want to ask everyone to continue to follow us on MD Newsline on Instagram, Twitter, Facebook, at MD Newsline, and to subscribe to our newsletter at mdnewsline.com. I just want to thank everyone, and we're looking forward to our next discussion. Thank you, Dr. Brittany.
Thank you so much for having me again.
All right. Take care,
Have a
guys.
good evening.
You too. Take care.